Good morning, everyone. My name is Sarah Nijs, Application Specialist at Molecubes, and I would like to welcome you all for our first live webinar. In this webinar, I will first give you an introduction on the Molecubes product line. So I will give you more information about our beta, gamma, and X cube. The beta cube is our PET system, the gamma cube is our SPECT system, and the X cube is our CT system. After this short introduction, I will give the word to Professor Van Hove. He's the head of the preclinical imaging facility at Ghent University, and he will present on his latest research with a focus on neurology and oncology applications. Finally, we will conclude this webinar with a Q&A session. So during both presentations, you can ask questions via the Q&A button in the chat window on your right at any moment. So after the webinar, Professor Van Hove and I will answer a selection of questions. The other questions will be answered by email afterwards. Also, after the webinar, we kindly invite you to fill in our feedback form that will be sent out via email. So let's get started. Here you can see an overview of our product line. So we supply preclinical SPECT, CT, and PET, respectively our gamma cube, X cube, and beta cube. As you can see, our systems fit on a benchtop, and they can fit both rats and mice. So you can image 1 rat or 4 mice simultaneously by using our mouse hotel. As you can see, we have a modular concept in which each cube represents one modality. So you can start from 1 or more cubes, and you can add as much cubes as you want. So you can upgrade without any downtime. For dual modality imaging, for example, PET-CT or SPECT-CT, you need, of course, 2 cubes, one for PET or SPECT and one for CT. If you would like to have all 3 modalities, you only need 3 cubes, since you can use the CT for anatomical correlation of both the SPECT and PET images. An advantage of our modular concept is that you can use all 3 cubes at the same time. In addition, you can also do both acquisitions and reconstructions at the same time, since each cube houses 2 servers, one for acquisitions and one for reconstructions. In addition, the systems can be operated in a wireless manner via an iMac workstation or via an iPad. So to summarize, we are the only benchtop system that can fit full body rats, and we also allow you to upgrade without downtime. So here you can see a table with our specifications, and I will sum up the most important specifications on the application side. So first of all, as I already mentioned, you can image both rats and mice. So for PET, our actual field of view is 13 centimeters, which allows you to do full body mouse or a rat from brain to heart region in one bed position. This is an advantage for kinetic modeling, since you can have both the brain and heart region in one bed position. Can you hear me again? Okay, so I will start again with this slide. So in this slide, you can see a table with specifications of all our cubes. I will not discuss this in detail, but I will focus on the most important features on the application side. So first of all, you can do both rat and mice imaging. For pets, our actual field of view is 13 centimeter, and this allows you to do full body mouse imaging or rat from brain to heart region in one bed position. This is an advantage for kinetic modeling since you can have both the brain and heart region in one bed position, so for a rat, and this allows you to obtain the image-derived input function. In addition, you can do both static and dynamic acquisitions with our systems. Second, we have a sub-millimeter spatial resolution, which enables detection of small lesions. Third, we have a high sensitivity, which is important to detect low tracer amounts, or which allows you to scan more animals with only one radiosynthesis batch. It also allows you to do longer dynamic acquisitions with isotopes with a short half-life, like for example, carbon-11. Fourth, we have state-of-the-art detector and reconstruction technologies. And lastly, we have a best-in-class in vivo CT, which can be used for anatomical correlation with PET or SPECT, thanks to automatic co-registration, but it can also be used as standalone advice. So the X-Cube allows you to do full body mouse and rat imaging. And a full body mouse scan can take only 25 seconds with a dose below 3 milligray. So this is our high throughput low dose protocol. So here you can see an example of a typical lab setup. So as I already mentioned, the cubes fit a benchtop and they can be operated in a wireless manner via iPad or an iMac workstation. Our user interface is also developed in-house and is very easy to use and intuitive. So you can start an acquisition in less than 10 clicks. So first you hit the cube you would like to use, then you fill in the study metadata, and then you set your scan parameters. So for PET, for example, you select the field of view. You can do this based on the numbers indicated on the bed cover or based on a quick scout scan that was done on the X-Cube. Then you can fill in the injection time, the isotope, the scan duration, and also the injected activity. Then you will have an estimate of the number of bed positions, and then you just hit the start button and your acquisition will start. Also, reconstruction is made very simple and intuitive and can also be started in less than 10 clicks. So first you select the cube, then you hit the plus button, and then you will see a list of all your acquisitions. And then for PET, you can choose the voxel size, you can select the CT dataset for attenuation correction, and you can define your frames. Then you just click add and your reconstructions will be added to the list. So to summarize, our beta cube is our PET system with an actual field of view of 13 centimeters, and it enables imaging in a broad activity range from 1 microcurie to 600 microcurie. And this is ideal for both dynamic and static acquisitions and also high throughput imaging. You can image 1 rat or 4 mice simultaneously. Then the gamma cube or SPECT cube is also suited to image both rats and mice and is an optimal compromise of resolution and sensitivity. It has dynamic capabilities and multi-isotope imaging is also possible. Then our X-Cube or CT. This is an ideal in vivo micro CT since it is fast and also low dose. In addition, our workflow is very easy and intuitive with minimal training required. In addition, all systems can be used at the same time. And lastly, our systems are compact with minimal site requirements and they have a low weight, so they can fit any lab space and they can also be transported between different rooms. I will conclude this introduction with an overview map of our installs in the past 24 months. So as you can see, we already have 2 installations in the United States, 3 installations in Europe, and 1 installation in Asia. So now I would like to give the word to Professor Christian van Hove. He is the head of the preclinical imaging facility at Ghent University, and he will present on his latest research. So I would like to mention also that you can ask questions during this presentation. So please use the Q&A button and not the chat function to post your questions. Thank you.
Hello, everybody. So I will try to share with you here some experiences and study results we've obtained here in Ghent at the Infinity Lab using the ModelCube systems. First of all, maybe for your information as a way of introduction, so Infinity is one of the expertise centers here of Ghent University with a focus on in vivo imaging of small animals, and mostly it's rats and mice. And we are pretty lucky that we have 6 imaging modalities available in our lab, and this includes SPECT, PET-CT, MRI, optical imaging, and ultrasound. We also have a small animal radiotherapy device available in our lab. Now, within our university, we are part of the Institute of Biomedical Technology, where we cover education, research, services, all related towards health technology. And this is part of the Faculty of Engineering and Architecture. Now, let's go now to the more interesting things. So I will share with you 10 study examples, which are currently running in our lab. Now, as you will see, if you move through these examples, you will see there's a pretty large variability in these examples, which is, to my opinion, typical for in fact core imaging facility such as in fact Infinity. Now, in the first 5 examples, the X cube was used. In the last 5 examples, the beta cube was used. For SPECT, currently, in fact, in our lab, it's mostly used only for contact research. So in there, of course, it's a little bit more difficult to share with you the study examples. Now, let's go to the first study example. Now, I will always give you a short introduction of the study example and then show you afterwards some images. So the first one, as I already mentioned, so we have a small animal radiotherapy device available in our lab to do treatment planning. This is based on a micro CT, which is on board in the system. And of course, the dose which has to be delivered by this micro CT should be as low as possible, because we have to do a micro CT each time we do a treatment planning. So if we do longitudinal studies, we have to do each time this micro CT, and the dose should be as low as possible. Also, of course, if we give irradiations, the delivered dose should be also as accurate as possible. And so therefore, we had a collaboration with a Belgian company. It's called DoseView, and they made the dose wire, which you can see here on the image as a kind of optical fiber. And with this optical fiber, you really can measure real time the dose during, for example, a micro CT scan. And for this device, it was a pretty low dose of 25 milligray during a scan of 1 minute. And of course, we were a little bit curious that we could confirm this for our other micro CT device, including the X cube. And as you can see here, so for the general purpose protocol, we also had a dose of more or less 25 milligray during, in fact, 1 minute. But as you can see, you can go to much lower doses using this high throughput low dose protocol. The images maybe become a little bit noisy, but then you have with the X cube the big advantage that you can use an iterative reconstruction algorithm, and during this reconstruction you also can do some kind of denoising, so based on total variation, and then you have an image which is, to my opinion, sufficient to combine with the SPECT or with the PET image to provide you some anatomical information. Now, if I compare the X cube with the other 3 micro CT systems in our lab, I think I can sum up that they provide high quality at a low dose, and especially they are pretty fast. And so these 3 properties are sometimes very useful. So here I give you an example which I didn't mention in this 10 examples in the beginning, but it's where we try to get a better understanding what happens in the brain in case of mild traumatic brain injury. And so there we follow up animals over time, mostly using MRI. But to induce mild traumatic brain injury, we use the Marmoro model, the Marmoro weight drop model, where we have a weight of 450 grams, which falls from 1 meter on the head of an animal. And the first thing what we have to check is that there are no skull fractures. So and therefore, we need micro CT with sufficient quality to see a fracture, also low dose, so that you don't have effect of the dose on the follow-up on the longitudinal study. And also, it should be fast to do it as efficiently as possible. And so here you see some micro-CT images of this head of a rat. So you very nicely see the structures here in the nose. You also see very nicely the dental structures here, and very nicely bregma and lambda here on the brain. And this you can get in less than 1 minute, and with effect, I think, a sufficiently low dose. Now let's move to the second study example, which was a collaboration with the Laboratory of Experimental Cancer Research. The idea here was to have a mouse model for carcinomatosis, more specifically peritoneal metastasis, which is a major cause of death in case of colon cancer or ovarian cancer. And so here they want to make a mouse model which fits as close as possible to the human situation. So what they did, they did a kind of 3D printing of biocompatible scaffolds. They are 6 millimeter in diameter, and they have a pore size of 0.5 millimeter. And so in these scaffolds, they put cancer-associated fibroblast cancer cells. So in this case, it were ovarian cancer cells, and also collagen. And then you put them into an incubator for 3 weeks. Then you can implant the scaffolds in living animals. You follow up the animals during 12 weeks. And then after 12 weeks, you sacrifice the animals, and then you can look to the microenvironment in the scaffolds. And that's what you can see here. And then you see that the microenvironment is pretty close to what they see in effect in the patient situation, which was, of course, very good news. Now, the question to our lab was, can we also see angiogenesis into the scaffolds? And so we decided to use for this contrast-enhanced micro-CT. So first of all, we had to do some kind of pilot experiments where we tested Exciton 12,000. So we injected Exciton 12,000, and directly after injection, we started a micro-CT scan. So in this case, we used this high-resolution protocol of, I think, only 4 minutes. And if you look to the head and neck regions in the mice, you see very nicely blood, the big blood vessels, but also the smaller blood vessels. And if you look very carefully, here in the brain area, for example, you also see the vasculature into the brain. If you look to the abdominal area, you very nicely see vascularization of the liver. Here you see also very vascularization of the kidneys, and also vascularization in the abdominal area, as you can see more or less here. And also, of course, you very nicely see on top here the region of the hearts. So if we look to these images, we were pretty convinced that we should see, in fact, angiogenesis in the scaffolds. And the results can be seen here on this slide. So the scaffold is positioned here. And if you look very carefully, sometimes you see really blood vessels running into the scaffolds. So maybe we can repeat it a little bit. So here's the scaffolds. And then if you look very carefully, you see blood vessels really running here into, in fact, the scaffolds. So here they cropped it a little bit and did some kind of 3D volume rendering, and there you see, in fact, these blood vessels in the scaffolds. Now on the contralateral side of this animal, there was also a scaffold, which you see here. And there they didn't load cancer cells, so it was a kind of control scaffolds. And if you look very carefully here on the micro-CT scan, there you'll see that there are, in fact, no blood vessels really running into the scaffolds. Now, this contrast enhancement was also quantified based on this kind of thresholding on Hounsfield units. And then you see that there's no contrast enhancement after 4 weeks, but after 12 weeks, as you can see here on the images, you see clearly contrast enhancement. And if you compare the tumor scaffolds with the control scaffolds, which you see here, you also see a significant difference of contrast enhancement in case of the tumor scaffolds. And this was, in fact, recently published in Biomaterials. Now, the next 2 examples are examples as a result of a collaboration with the Department of Gastroenterology. There are, in fact, 2 focuses here. So one is hepatocellular carcinoma, or HCC. So mostly to do this, so you have to inject intraperitoneally a compound called DEN. And then you have to wait typically for, let's say, 25 weeks. And then you have, yes, you see, in fact, HCC in the liver. But mostly these are very, very small nodules, and not actually the same what you see in a human situation where you have these small nodules, but you also have larger tumor masses. And the question to our lab was, so they fine-tuned a little bit their animal model. And the question was, can we see in vivo, also this larger tumor mass, which should appear in this modified mouse model. And so again, we decided to do a contrast-enhanced micro-CT, again, using Esiton. But this time, we did the acquisition 24 hours after injection of Exitron. So then this kind of nanoparticle, so it moves from the blood pool to the liver. And then you see clearly here enhancement of the liver. And so here, on this place here, also here, for example, here and here, you see in fact this big tumor masses, which appears in the liver, and which in fact was good news for in fact these guys here from this research group. And I think they're also preparing here a paper. Another focus with these people from the gastroenterology department is inflammatory bowel disease, or IBD. So mostly they ask us to do some functional imaging using SPECT and PET to look to different aspects of IBD. And what they also mostly ask is to combine this with a micro-CT scan, where you can see the difference between the inside of the intestines, the outside, of course, of the intestines, but also the intestinal wall. And so then we do a kind of dual contrast enhanced micro-CT. And so then we give gastrographin rectally and orally, and then you can see the insides of the intestines. Then we also can, for example, inject Exiton. And then if you look very carefully, you also see the wall here of the intestines. And if you take a little bit more closer look here, you see clearly the inside of the intestines. Then you see here the wall of the intestines, and then in fact the outside of the intestines. So if there's, for example, inflammation, then you should see it here in the wall here of the intestines. And then a last example where we used the X-Cube was a collaboration with the Department of Dentistry, was related to age estimation. So if you don't know the age from someone, one thing you can do is a nuclear imaging technique, which is a bone scan, where you look to the growth plates. But this, of course, requires to use radioactivity. Another way is to look to the development of third molars, but then you have to do a radiography. So you also need to use ionizing radiation. And so these guys, they try to make a kind of MRI protocol so that you can look to the development of these third molars without ionizing radiation. And so in this study, they really try to compare MRI with radiography, which is in fact more or less the gold standard, but they also extracted the third molar, and then they asked us to do a kind of sample scanning of this third molar, which was then used as a kind of gold standard. And so here the X-Cube was used as a kind of sample scanner, and you very nicely see the structure of the teeth here. And what we have to look at is to the dental roots, and more specifically to the apex of the dental roots, that this apex is closed or not closed. And if the apex is closed, then it means that someone is older than 18, and if the apex is not closed, then is younger than 18. So this brings me to the end of the X-Cube. So now I will show you 5 examples where we use the beta cube. A first example is a little bit what Sarah here from Molecules did during her PhD. And so it's the in vivo quantification of hepatobiliary transport, which is important to look, for example, to drug toxicity in development of new drugs. Now, Sarah, so what you have to do then is, in fact, you have to label bile acids. Sarah did it based on technetium. And then you have to start a dynamic scan, and then you have to measure the activity in the blood. And normally you should have a pretty fast blood clearance of these bile acids. You can measure also the activity in the liver, which should go up first and then go down. And then the activity in the intestine should go up. And then if you, for example, give it a drug which is toxic, these curves will change. Now, Steph tried to continue a little bit the work of Sarah, but he tried to label these bile acids with fluor 18. And so what you see here on this slide is such a scan with the beta cube. So what you see first is the injection of the tracer, where you see the blood pool, and you see that the tracer clearly have a fast clearance from the blood pool to the liver. And then in the liver, you see activity going up and then going down, and then you feel the intestines, and there you see clearly that the activity is going up, and also here in the gallbladder. So what you can do is you can draw regions of interest over different organs, make time activity curves, and then in fact do some kind of semi-quantification. What you also can do is absolute quantification by using kinetic modeling, but then you need an input function. And if you want an input function, of course, you have to do arterial blood sampling, which is not always very easy in mice. So what you then can do, and this is what Steph all the time does, is so after each scan, you inject FDG, and then you can visualize the heart of a mouse. And then if you take a little more close look, you very nice to see the left ventricle, and also here, in this case, you see the right ventricle, and then you can draw a region of interest here in the left ventricle, copy this region here on this data here, and then you can obtain what we call an image-derived input function, which can then be used for kinetic modeling. And in this way, we have an absolute quantification of the tracer kinetics, which then can then be, for example, be used to evaluate drug toxicity. Now, the next two examples are related to our research in the field of neuro-oncology. There we have two research topics. The first one is related to glioblastoma. As you probably know, it's a terrible disease with a median survival of more or less 12 to 15 months. A lot of drugs have been tested, but mostly you can increase a little bit lifetime. But mortality didn't change during the last 20 to 30 years. And so we also try to improve treatments in case of glioblastoma, but more based on radiotherapy. And to do this, we need, again, an animal model for glioblastoma. And I think we have a very nice model here where we inject this F98 cell line into the brain of rats. And then if we do MRI, which is exactly what you also do in patients, you see signature, which is more or less the same as you see in patients. So you have a necrotic area, you really see the tumor, you see here tumoral infiltration, and then you see the normal brain tissue, which a little bit match pretty well with what you see in histology. And we also developed a MRCT-based workflow for radiotherapy, which is exactly the same way they do humans. So where you use the MRI to define effector targets, or you use CT to do those calculations, and then you give multiple beams for multiple directions. Again, exactly what you do in patients, to give a high dose to the tumor and to spare effector normal brain tissue as much as possible. Now, if you give no treatment, you see that the tumor really grow exponentially. If you give radiotherapy, you can see that you can stabilize tumor growth, but then after a while, the tumor explodes again, which is again also what you see, in fact, in the human situation. Now, what we try to do is PET-based radiotherapy. And so the idea there is to give a higher dose to the more aggressive part of the tumor and a lower dose to, in fact, less aggressive part of the tumor. But what we then need, of course, is a PET scanner where we have sufficient spatial resolution, ideally, I think, millimeter spatial resolution, to see, in fact, the heterogeneity of the tumor. And here you can see an example of the beta cube. So it's injected with FDG. And here you see, in fact, the tumor. You also see the tumor on the MRI. And you very nicely see the heterogeneous tumor with the necrosis in the middle, higher activity of FDG here, and lower activity of FDG there. And so the idea is then that you first delineate the tumor on the MRI and give a kind of uniform dose on the tumor, which we do usually. But then you also give a boost on the part of the tumor with the highest, in this case, FDG uptake, which is here, for example. And then, so it's a study which is currently running in our lab. And so we hope that we can, in this way, also try to improve effect survival in these animals. Another part of the neuro-oncology research is related to brain metastasis, and more specifically, brain metastasis from breast cancer, which is a major cause of death in case of breast cancer. So there we try to develop a rat model. So we inject breast cancer cells into the left ventricle of rats. This is guided by ultrasound. Then directly after injection, we can do MRI to check that, in fact, the cells arrived in the brain, as you can see here. And then we follow up animals over time using the MRI. And then you see, after a while, you see, in fact, brain metastasis occurring into the brain. And when we see, for example, the brain metastasis, we can start to try some kind of new kind of treatments. The problem here was that the animals were paralyzed before we could start with the treatments. And then we asked, of course, the question why this is the case. And then we did maybe what you should do also in the clinic, a whole body PET-CT scan of this rat using FDG. And then you can see clearly here that there are, in fact, a lot of lesions here present into the body. If we then combine it with a CT, then you see that these lesions are, in fact, present in different bony structures of the animal. And if we take here a closer look, then we see here, for example, high uptake of FDG, and you really see here the bone is really eaten away by the tumor. The same you see here, and the same here. So part of the tumor which is really eaten away by the tumor, and also here. And also here you see some more bone lesions on the CT. So initially, this model was in fact made for mice. So we tried to use this model in rats. It seemed that it not works perfectly well. So now we try to fine-tune this model a little bit so that we also can use in fact this brain metastasis model in rats. Now something completely different. So this is a collaboration together with the University of Brussels. They have big expertise in nanobodies. And so we try to label these nanobodies with fluorine-18, and we try to look to nanobodies to visualize atherosclerotic plaques. So again here, so you have to do this in mice. So we have to look to very, very small lesions. So we need in fact a scanner with pretty good spatial resolution to see in fact these small lesions. And here the idea was really to compare the beta cube with our other PET system. So here we scanned 6 mice in a kind of crossover design, which were injected more or less 40 megabecquerel of this radioactive labeled nanobody. We scanned 2.5 hours after injection, and we did a 30-minute PET scan. I used in fact the same reconstruction algorithm. So what you see here clearly is that the images of the beta cube are much less noisy, and this is probably due to the high sensitivity. But also, if you look carefully, you see a very small lesion here. You can also see it here and also here, but it's not very nicely to see on the LAPET scans. So we try to quantify this, and therefore we draw a region of interest over the aortic area, the second region in the brain, and then we calculate target to brain ratio, and there we see that it's significantly higher in case of the beta cube, which means that it's more easy to see in fact these small lesions using the beta cube. Now, as a kind of control experiment, we did a kind of blocking experiment where we give an excess of unlabeled nanobody before we inject the labeled nanobody, and then in fact you don't see a significant difference between in fact the 2 scanners as in fact it should be. Now, a last example is an example of a really translational study where in fact we use rats at Infinity, dogs in collaboration with the veterinary imaging departments, and humans in collaboration with nuclear medicine department and department of psychiatry. And there we want to have a better understanding of what happens in case of depression, and also what's, for example, what happens during a therapy called TMS. And so we look to glucose metabolism, dopamine system, and serotonin system. So we're using a variety of tracers. The problem here is if you look to small animals, let's, for example, reclopride, so it's the dopamine 2 antagonist. It's labeled with carbon 11, so it's a pretty low half-life, and therefore it's very difficult to make the compound with very high specific activity. But also we should inject a very small mass of the protein, which means that we should inject a pretty low activity to have a target occupancy which should be lower than 1%. So here we try to inject an animal with only 5 megabecquerels of raclopride, and still you very nicely see the 2 striatoms. And if you draw dynamic curves, so time activity curves, they look pretty smooth, they're not too noisy, and so you can put this again into a model, for example, simplified reference tissue model to do some kinetic modeling, and in this way to do absolute quantification of in fact the tracer dynamics. Now, we did then a kind of experiments for fun. So how low we can go in activity. So here we used mice, which we injected with sodium fluoride. And then we, as you can see here, so we decreased the activity. We went lower and lower. And finally, we came up to more or less 1 microcurie. But even then, if you increase your acquisition, for example, to 20 minutes, then you see still some details here, and the images are not too noisy. And I think this is, of course, the effect of the combination of having submillimeter spatial resolution and this very good sensitivity of the beta cube. And so this brings me to the end of my presentation here. I hope that you learned something from this presentation, and I would like to end by thanking you for your attention.
Thank you, Professor Van Hove, for your excellent presentation. We will now have a short break to have a look at your questions, and we will be back in 2 minutes to answer those questions. So stay online. Okay, so we are back for the questions. First, Professor Van Hove will answer 2 questions, and then I will answer 1 more technical question.
Yeah, so one of the questions was which activities you will recommend for standard scans of mouse and rat studies. So I think for if you use mouse scans, I would recommend you use more or less, let's say, 2 megabecquerels or 50 microcuries to inject. And for the larger rats, I will go to, let's say, 7 megabecquerels, so it's more or less 150 to 200 microcuries. I will not change, in fact, this activity if you do dynamic scans. So I will use, in fact, their same activity. Another question was related to the contrast enhanced CT, so related to Exitron. So what was the dose we used? And so what was a little bit more details about the protocol? So here we used an injection of 150 microliter of Exitron, and this was done using an infusion pump. And so injection was done over 2 minutes with the pump, and then mostly directly after injection. So it was, I think, more or less 8 minutes after injection. We start the CT scan, and so then the contrast stays more or less in the blood during, let's say, 6 to 8 hours, and then you will see a more and more uptake into the liver.
So then we also had a technical question on how the automatic registration is achieved between PET or SPECT and our CT cube. So first of all, our bed stage is designed to ensure that the connected bed is always in the same position. And then secondly, we compensate for inter-system variability using a co-registration matrix. So this co-registration matrix is measured during installation and is then calibrated. So all your next scans should be co-registered automatically. So the output of our is DICOM. So you can load these DICOM images in every post-processing software, and they are fused automatically. So those were the questions. I would like to conclude this webinar, and I would like to thank you for your kind attention. Thank you.